My name is Mary Lloyd Ireland, and this presentation is on hip and thigh cases, surprises. I presented this at the American College of Sports Medicine, Essentials of Sports Medicine, from the sideline to the clinic, formerly ACSM's Team Physician Course, Part 2. Meeting was in San Diego, February of 2017. The objectives to show hip and thigh cases which have unexpected final diagnosis, be able to interpret radiographic images of the hip and thigh. These are cases that I have seen personally that have surprised me, and I hope that it will make it less of a surprise when you see some of these cases. So think about these unusual diagnoses. I have nothing to disclose. So what's the diagnosis on this one? This is an AP of the pelvis, 18-year-old athlete. You can see the opacities in what looks like the sacrum. Think about this and think what this would be. Doesn't look bad, looks very unusual. This is actually the hydroculator worm pack that was on their back that was not taken off when the x-ray was done. So usually the people taking the x-rays remove clothing, remove ice, remove hydroculator packs, but sometimes they don't. So if it looks unusual, like it might be part of a warm-up, or in this case a hydroculator pack, ask the patient if they had something on their extremity or their back when the x-ray was taken. So this is an easy diagnosis of AP pelvis is normal, but the hydroculator pack looks like this if you take an x-ray without taking it off the patient. 24-year-old graduate student who was getting his master's in exercise physiology. He complained of left groin pain for about 6 months. When he came in, he stated that he has an osteoid osteoma of his left hip. Most of the time patients aren't quite that specific with a diagnosis or sophisticated, but I listened to my patients and I heeded his diagnosis. These are his images. So you can see on the plain film, AP of his left hip, femoral head looks normal, acetabulum looks normal, the femoral neck looks normal. This is his lesser trochanter, greater trochanter. So everything looks okay there, but if you look, he's got a second lesser trochanter. So he has this bump right inferior to the lesser trochanter. This is a CT scan, and this is what the CT scan looks like. So you can see the cortical bone is very thickened, and there is this radiolucency that's consistent with AIIS. And here is his bone scan that did not light up on this scan. So we have a cortical thickening with AIIS, and that is an osteoid osteoma, as the patient stated he had. He had researched it. His pain got better with taking anti-inflammatory medications, so that was a prostaglandins inhibitor. Osteoid osteomas secrete prostaglandins, so a classic history finding is that it gets better. Pain gets better. Usually it's worse at night. It gets better with taking anti-inflammatory medicines, non-steroidals. And this is what is done for this. This was a while ago, so we did do an open approach. Some ablation surgery could be done now for this osteoid osteoma as techniques have advanced. This can be done under x-ray guidance, but I did an excision of this osteoid osteoma. He was a thick guy, so the approach was an adductor Ludloff approach that's a little easier in a pediatric patient. But basically we had a deep hole, and this was after his excision of his osteoid osteoma. We did scan this to make sure that we had it all. So listen to your patients. He was right. Patients can oftentimes be right, and listen to them carefully. Tumors of bone. This is from textbook Atlas of Tumor Pathology. This is what the appearance is of an eosinophilic granuloma. You can see here it is in the cortex medially, again the lesser trochanter, and then this is what an eosinophilic granuloma. Insidious onset of pain in the left thigh for 3 weeks. Get good plain films to start off with, and then do your workup. This lesion was interpreted as osteomyelitis or Ewing sarcoma, but is an eosinophilic granuloma. Another X-ray appearance, this is tumoral calcinosis. Looks a little like that hydroculator pack, but this is a soft tissue extraarticular process tumoral calcinosis treated by excision. This is what the appearance of this is, of the left hip. This is another eosinophilic granuloma in a younger individual. Again, I think it's important to look to see what the reaction to the bone is. This is a locally aggressive tumor. This is a solitary cyst, so you can see the cortex is thinned, but it isn't really reacting to this, so this has been previously treated with injection, but a solitary cyst that can be treated with observation. However, if this person is in a collision sport, you would be concerned that there would be risk for a pathologic fracture through this weakened bone. Again, not a malignancy, but a potential problem if they're doing a contact sport. Intervention to increase the chances of healing with injections can be done. If they do fracture, usually the cyst will go away and hopefully the fracture is not displaced. Localized myositis ossificans. We see this in football athletes who get hit with a helmet to their anterior thigh. Need to look at the tightness in their thigh and also examine their knee. The more severe myositis ossificans of the thigh also have a sympathetic effusion of their knee and limited flexion range of motion. So this is a characteristic dotted veil pattern in this localized myositis ossificans. Basically treated with observation. Anti-inflammatories of indocin do seem to help this better than other anti-inflammatory medications. This is a patient that I treated. You can see here his initial x-ray that was actually about a week after his contact helmet to his thigh. Then this was at 3 months and this was at 6 months. So you can see how the bone matures over the course of months. Treated with observation, working on active knee range of motion, indocin, NSAIDs. On occasion, radiation can be done in these individuals, but this is treated non-operatively, watching this mature. If you do a biopsy of this, this could be confused with a more aggressive process such as an osteosarcoma. With an osteosarcoma, the more aggressive cells are in the periphery, opposite in myositis ossificans. This is a 17-year-old high school junior who was hurt on a kickoff. He had a direct blow to his thigh. The player that hit him was knocked out, so more attention was placed on that player who had a serious injury. The patient didn't go back to the game, but the next day came into the Saturday walk-in clinic with severe pain in his thigh that continued to get worse. His pressures measured in his thigh were 80 millimeters of mercury, with a normal should be less than 20. So he underwent emergency fascial releases, fasciotomies, and he did well. Post-operatively, he did so well that he wanted to get back to play the end of the season, so he wanted to get to play after about 6 weeks. Fortunately, the other opinion, another orthopedist that he went to, did not allow him to play. So this emphasizes how we take care of these patients, and we as sports medicine physicians should make sure we are all on the same page, and particularly if somebody has had a potentially limb-threatening injury, not allow them to go back in the situation where another orthopedic surgeon has operated on them. So fortunately, the orthopedist did not clear him to play, and we need to communicate well and be on the same page. This is what his thigh looked like. This was the rock hard thigh. This is when we're doing his compartment pressures. And this is after his fascial release, so we cut the fascia, don't repair it. I was able to close him initially. Fortunately, the muscle looks normal. And this is his range of motion and his wound at 4 weeks following the surgery. Again, looks good. You can see how much smaller his thigh is from that initial rock hard thigh compartment picture. It's unusual to have a thigh compartment syndrome after a soft tissue injury, much more common after a femur fracture. This next case is a family practitioner who was training very hard, very intensely over a very short period of time for a July 4th run. He actually started training about 6 weeks before the July 4th run. He significantly increased his mileage over a couple of weeks, and he complained of right groin pain. As a family practitioner, he had X-ray access and MRI access, so this is a case that shows the progression of healing in a femoral neck fracture on the compression side. This is his initial X-ray. He'd had symptoms for a couple of weeks. It's his right hip. So as we look at the hip, here's the femoral neck. The femoral neck is an intracapsular structure, so we won't see callus formation, or we may not see anything with a femoral neck stress fracture acutely. This is where if somebody has groin pain, has female athlete triad, has previous stress fractures, or has an increase in intensity of their training, and you suspect a femoral neck stress fracture with groin pain, I would do an MRI scan early on to make a diagnosis. This is what he had done. He had this 5 days after his pain had increased, so he'd been running intensely for a couple of weeks. And this is his increased activity of the compression side of his femoral neck. And you can see here on this T2 weighted image where there's all the white and the extensive involvement with bone changes, bone edema from the stress fracture. Left hip looks normal. And this is his bone scan. Maybe not necessary, but you can see his increased activity in the inferior medial compression side of the femoral neck. And at 2 months after his injury, you actually can see a little reaction there, even though this is an intracapsular structure. But you can see here where that looks good because it's healing and there is not any change in the femoral neck cortex here inferiorly. Again, this is the compression side. We'd be more concerned about the tensile side, and that would have been fixed in situ before it displaces. So he basically was on crutches, was able to work, but certainly didn't do his July 4th 10K run. So now at 3 months after his stress fracture, 3 months into this, you can see how the MRI scan looks like it's getting worse, but that's more of the healing reaction of the bone. And this is 3 months and correlates with this X-ray. So sclerosis, the body is healing. And then at 4 months, you can see progression of this sclerosis, no displacement. He ended up doing well, had no problems or no recurrent stress fractures. He just didn't train that intensely over that shorter period of time again. This next case is a baseball catcher who had been having some groin tightness for about a year. He finally came in. He was a tough individual, played football, baseball, and basketball, but what really bothered him was getting in the position of catching. No injury that he could think of. And he just felt like he was tight. So if you look at his x-rays, he'd now been having symptoms for a year, never had had x-rays before. This is ectopic bone in the adductor tendons or the adductor muscle here. So you can see here on the right side, he's got a little irregularity. Didn't really have any pain on that side, so he might have had a previous adductor injury on that side. but this is the ectopic bone that looks pretty mature in his groin, and we basically told him there wasn't really much to do, but it was good to diagnose why he had this tightness. For symptomatic relief, taking anti-inflammatories might help. He can stretch some. His hip itself really looked okay. There was no problem with his acetabulum or femur. It was more tightness because of this bone that had formed in his adductor tendon and muscle. This is a 9-year-old football athlete who was playing linebacker and basically was crushed. He had deformity of his left hip. The emergency room felt he had a testicular torsion, which was a very curious diagnosis since I'm not sure how the left testicle could have been examined since the patient's hip was in a position of adduction and internal rotation. As you can see here, the diagnosis really was a posterior dislocation of his left hip. So this is a view from the front, an AP view. You can see here his femoral head is not in the acetabulum, so he has a dislocation. It's a little hard to get a posterior view, but based on the position of the patient's limb, if he's posteriorly dislocated, his hip is going to go into adduction and internal rotation. I saw him a couple hours later in the emergency room. You get concerned about involvement in a 9-year-old of his proximal femur, Salter-Harris fracture of his proximal femur. The diagnosis was a posterior left hip dislocation. You can't really move these patients very easily with their hip dislocated. Unfortunately, his hip stayed out for about 3 hours, and when I saw him, I reduced him in the emergency room after IV sedation. So beware a lot of pain in an individual who had a significant injury, pile up in football, and look at the position of their limb. So these are his initial films. We got as best lateral as we could, so he had a posterior dislocation. His femur really looked okay, so it didn't appear that he had any involvement with his femoral head. This is his femoral head. His epiphysis is here. His greater trochanteric apophysis is here. And this is post-reduction. You can see better his growth plate and his triradiate cartilage here, confirming this is post-reduction, pre-reduction. In reducing a hip, the best thing to do is get up on the table and use your leverage effectively so you don't hurt yourself or the patient. So that's the position that the hip is in when you have a posterior dislocation. And in an individual that's a little smaller, you might be able to reduce it, but basically you want to bring the leg anteriorly, and what I like to do is to get up on the table and apply traction, consistent traction after IV sedation, and it takes a lot of traction to reduce a hip. So it's better to do this in an emergency room and not try this on the field. So pull up, and rotation sometime will help where you gently rotate it in and out and just do like a squat thrust on the table. This may shock individuals in the emergency room or the operating room. Make sure the table is sturdy enough to support you and the forces that you're going to put on the table to reduce the hip. The sooner that we can get the hip back in place, the better it is, and the less likely for avascular necrosis or other problems. This is the patient's CT scan after his reduction. Just want to make sure that there weren't any bony abnormalities, and this is his 3D reconstruction. See his epiphysis of his femur proximally. Lateral view, 3D CT reconstruction. He ended up doing fine without any problems following this injury and reduction. However, he did say I was going to pull his leg off when I was reducing him. This 13-year-old complained of knee pain, both knees, for about 18 months before he was evaluated by me. He had significant pain on range of motion of his hips, but he complained of the pain not in his groin or his hip, in the front of his knee. He had limited internal rotation, and when you brought his hip up into flexion, he went into external rotation and had no internal rotation. So whenever you see an adolescent with knee pain, make sure you examine the hip, look for symmetry of range of motion, particularly internal rotation, and know that hip pathology can radiate to the knee, and they may not know it's a hip problem. You're the one that's got to figure that out. This is his x-ray. It was his left hip that bothered him. You can see a little difference in the x-ray of his hip. Here's his right hip. See how the bone looks a little more osteopenic, and again, this has been going on for 18 months, and there's a little more thickening of the radiolucency, or a little more radiolucence proximal femoral epiphysis compared to the other side. The acetabulum looks normal, the femoral neck looks normal. And this is a case of a slipped capital femoral epiphysis. The direction of the slip, it goes posterior first, so you have to get a lateral view. This is his range of motion of his hip, so it's his left hip that bothers him. You can see as I bring his hip up, he doesn't get to zero internal rotation at all. He goes into external rotation, and any movement of his hip creates some discomfort at his groin, but more discomfort at his knee. So he has no internal rotation and about 30 degrees of external rotation. So this is how he's walking. You can see how his leg is externally rotated. He has a Trendelenburg gait. He can't really support his weight very well on his left side, and you can see his pelvis is rocking back and forth. When I do a Trendelenburg test on him, standing on his left hip, normally he should be able to hike his right side up, but he can't do that. So when he stands on that side, see how the right hemipelvis is lower? That's because of weakness of his hip abductors. He doesn't do much better on his right side. So he has a slipped capital femoral epiphysis that required pinning in situ. He later on went on to have the right side symptomatic and had that pinned. So this lateral view, you can see better that abnormal relationship of the femoral epiphysis, where it slips kind of like the ice cream on a cone, where it goes posterior inferior is the direction. So you may not be able to see it as well on the AP view. You do have to get a frog lateral view. So the ice cream slips inferior posterior, and you can see it best on the frog lateral view. Other adolescent problems, there are ossification centers and apophyses about the hip. The iliac apophysis appears from age 11 to 14 and closes by age 20. We see iliac apophysitis, or where the abdominal muscles insert on the iliac apophysis, particularly in running or soccer sports. You may have pain over that iliac apophysis. There are other apophyses, and understanding when these apophyses appear and when they fuse is important to be able to make a diagnosis. So the appearance of the epiphyses, ossification centers, and apophyses are very important if you're treating adolescent athletes. There are avulsions that occur in these apophyses. You can look at textbooks to see when they appear and when they fuse. An even better live textbook is the opposite side to compare. So the anterior superior iliac crest is where the sartorius originates. The rectus femoris originates at the anterior inferior iliac spine. Insertion of the iliopsoas is on the lesser trochanter, and the hamstring origin is on the ischial tuberosity. So the path of least resistance in a skeletally immature individual, we see these more in adolescent males, is through this apophysis. Mature individuals would have injuries occurring in the muscle itself, or for example like a hamstring strain, but these skeletally immature injuries occur where the apophysis is the path of least resistance, and you can have fractures through these apophyseal areas. So when we put the muscles to it, this shows the sartorius, rectus femoris, hamstrings, and then the abdominal muscles inserting here are the internal external obliques, transverse abdominal musculature. The iliopsoas, or the filet mignon muscle, inserts on this lesser trochanter. This is a 15-year-old with a sartorial avulsion. So this is his initial presentation, and again, you just get plain film, so you can get an AP pelvis, and sometimes you get a marked view or an oblique view. So this is at his time of presentation, and this is as he's healed. So this is an avulsion of the sartorius, origin through the ASIS apophysis. This is a rectus avulsion of the anterior-inferior iliac spine. This was displaced, but fortunately did go ahead and heal. We don't tend to fix these in these individuals because they will go ahead and heal. But you can see where the AIIS is here, the ASIS is here where the sartorius originates, and the rectus femoris is at the AIIS. This is a baseball athlete. He was stretching in the gym. He felt a pop in his groin. Here's his right ischial tuberosity, apophysis avulsed. Here's the left one. Doesn't even look like it's still open, but it is. So this is a bit displaced, but it does go ahead and heal. You have to back him down for a while. This is a lesser trochanteric avulsion of the iliopsoas insertion. 14-year-old soccer athlete. Again, you can see there's a little displacement there, but these will go ahead and heal. Snapping hip syndrome are two types. There is an external that is the iliotibial band on the greater trochanter. This is the most common type. We see it a fair amount in dancing. There's also internal snapping hip syndrome, or coxasoltans, and this is the iliopsoas tendon rubbing on the anterior capsule, oftentimes seen in ballet dancers, thin individuals. The patient can usually demonstrate the popping, sometimes thinks that their hip is coming out of place, but this is the tendon rubbing on the greater trochanter of the IT band laterally, or in their groin, the iliopsoas, between the anterior capsule and lesser trochanter. Treated in general with avoiding that position as much as they can. More aggressive treatments would be ultrasound-guided steroid injections or hip arthroscopy. Remember, rheumatologic and infectious diseases is a cause of hip pain in the juvenile patient. Hip pain that may be insidious, where they limp, limited range of motion. Things to consider would be juvenile rheumatoid arthritis, juvenile psoriatic arthritis, septic arthritis such as gonorrhea, MRSA, Staphylococcus aureus, or Streptococcus. Dr. Burt Fields provided me with this juvenile psoriatic arthritis case involving the hip. So a 14-year-old girl complains of left hip pain, worsened over the last 3 months, strong family history of psoriasis. Psoriasis can have joint involvement. And this is what her hip MR looks like. You can see the fluid that's in the joint, and the femoral head has some degeneration of the articular cartilage. So think about other things such as tumors or arthritides, in addition to traumatic reasons for hip pain in juvenile patients. Thank you very much for your attention.